welcome everyone. I am Rachel, Community Manager here at Alloy Women's Health. We are a digital health platform bringing science-backed, evidence-based menopause hormonal solutions direct to your door. Today, I am so pleased to welcome OB-GYN and Alloy prescribing physician, Dr. Kudzai Dombo, to this space for the first time, where our library of information lives, our YouTube channel. And we're going to be speaking today. It is, I should say it this way, it is an Ask the Alloy Specialist conversation. Quickly, before we get into it, I just want to let our listeners know that today you may save $20 off of any Alloy purchase using the code DOMBO20. And finally, please drop your questions into the Q&A and I will facilitate those for you as we go along. Welcome, Dr. Dombo, to the Alloy platform. So happy to have you here. You are a member of the family, and we're going to get right into it. Because this is an Ask the Specialist kind of a conversation, I did get some questions direct to me in my DM, so I'll get through those with you. But primarily, we're going to be hearing from women who have questions for a clinician. And before we get there, if you would sort of frame us up with some education about hormones. So estrogen, progesterone, and testosterone play critical roles in women's health. Can you start by giving us a clear breakdown of what each of these hormones does for the body and why they're so important, especially in midlife?
Yeah. Well, thank you, Rachel. It's a pleasure once again to join you. And again, the most important thing that I think I want to relay to everyone is that this is a space where whatever comes up for you, please feel free to ask any questions. The time is yours. We honor the fact that you took the time to be here. And we also want to honor that whatever questions or concerns you have, we want to make sure we get to that as well. So thanks, Rachel. I thought the way that we would start is typically how we start everything is we can kind of just go through some quick definitions and then we'll talk about the three main hormones. And then I also want to make sure that we leave enough time for all the questions that people have. So, okay, we know menopause. The definition is 12 months without a period, right? And peri means around. It's, we think of a perimeter, right? When we think of an area that we're considering. So perimenopause is like up to 10 years prior to that time, and, at least a year after, right? That 12 months. So when we think about perimenopause, you may not necessarily have had any period changes, but you may have some of the symptoms that come with menopause. So what are the three main hormones that we think of and consider when we think of this midlife transition time? So we know that estrogen, progesterone, and testosterone are the three main hormones. There are a lot of different hormones that the ovary produces, but those are the three main hormones produced by the ovaries during this time. We notice that there are either wild fluctuations, right, in the release of these hormones, and then an eventual decline. So, estrogen, okay, it has some great positive effects on the body when we add it to our system during this time. But then there are also other things where how do we know if there's too much, or how do we know if, and I'm not talking about the first 2 weeks after starting like any kind of hormone therapy, because it takes some time for the body to adjust.
Sure.
But if we're looking at like 3 months in and I'm experiencing this, could it be like a downside to some of the hormones that I have added, to my body to really help me adjust during this time?
Yeah.
Right? So that's kind of where I thought I would start with it. So let's start with estrogen, right? We all know that it reduces not only the frequency, but also the severity, right, of hot flashes and night sweats. So let's say you notice that you're having really, really disturbing and troublesome hot flashes, or you may not even be having, ones that are that bothersome, but we do know that it will reduce the severity and the frequency, okay? Vaginal and urinary health. We know that adding estradiol to our system will help, or any estrogen, right? Not just estradiol, but, estrogen will help improve our vaginal and urinary health. estrogen can also act as a mood stabilizer, right? So whenever you have those fluctuations in your estradiol levels or, during perimenopause, it can lead to mood swings, irritability, depression. And so when you are experiencing all of that, like sometimes incorporating estrogen in one form or another can improve not only your mood, but also it can improve your cognitive health. So
Yeah, I can speak to this personally. I'll just
I
insert
think
that there. Yeah, big
I think
difference.
a lot of people can, because the way that you present, right, is going to be different for each person, right? Each person, not everybody's going to have hot flashes. Not everybody's going to have night sweats. Not everybody's going to experience mood changes. Some people, the most bothersome symptom can be joint discomfort, where they notice that, man, I was able to work out and do certain things. And now, like, either my elbow, my shoulder, like I'm just not able to extend it as easily as before. And that may be very distressing, to someone. So again, it's looking at the fact that they're positive, benefits, but then, if too much, we'll talk about, the con side as well.
Sure.
So I also think about, and you can stop me, Rachel, at any point where you think, okay, we want to do a deeper dive in that.
Sure, sure.
But bone density, right? We look at maintaining our bones and our bone health, whether it's, the bones in our body or even in our jaw, right? Because that'll impact our dental health.
Hmm.
Bone density is something that adding, estrogen in some form will help with that. Our skin health, a lot of times we notice as we age, right? The moisture in our skin. Like I had oily skin up until like a certain point in my life, and then all of a sudden it's dry.
Dry as a bone. Yeah.
Right. So really looking at the skin elasticity, right? Moisture resilience, of our skin. That is something that, by the addition of estrogen, that can help, really show difference, in our skin health. Cardiovascular. So we look at our heart health, right? Blood vessel health, we look at our cholesterol, estrogen, adding estrogen, again, depending on the form, can really reduce our cholesterol. It can improve our blood vessel health, and it also can improve our circulation. So, but it's important again to make sure you start it at a certain point. You want to
You
start.
mean age or?
So when you introduce, yeah, so the age introduction, because once you, like, there's an optimal window of introducing estrogen to notice a significant difference in your cardiovascular health.
Okay.
That's what I mean about, when it comes to cardiovascular health.
Okay.
Yeah.
And that would be,
So within, under age 60 or within 10 years of your last menstrual period,
okay.
that's the time where we
Excuse me.
consider it, the best
Mhm.
time. Okay. And, when you think about all the different things, like even sleep quality, right? Some women have trouble falling asleep, but other women wake up at 2 a.m. to go to the bathroom and can't fall back asleep, right? I've noticed that estrogen can be more helpful for the 2 a.m. being able to fall back asleep. Uh,
Sure.
so, and again, those fluctuations are what cause a disruption to your sleep pattern.
Okay.
Okay.
So you've laid out really, I think, sort of the internal, external positives of estrogen,
Right.
from mental health, emotional health, anxiety, mood stabilization, to bones, skin, heart, what did I miss? Vaginal health, and sort of dealing with the vasomotor symptoms, the hot flashes, the night sweats. So before we pivot to sort of understanding what's too much or too little, give us a little insight into progesterone.
Okay, yeah. So progesterone, the main reason that we add progesterone, even though it is a hormone that is produced by the ovary during our healthy lifespan, right? But it really serves to protect that uterine lining from overgrowth, because estrogen, again, it has many great beneficial effects, but it also can cause that uterine lining to overgrow and lead to what we call a condition called endometrial hyperplasia, which, if left unchecked, can progress to cancer. So
Right.
one of the things we want to do is just make sure that, the balance of protecting that lining is there. So that's the main reason we add progesterone to a regimen. But it's also like bioidentical progesterone has been found to improve sleep quality. So it has this hypnotic effect, right? So it lulls you into a trance, is what I think. You know, hypnosis is lulling somebody into a trance. So it really helps falling asleep. I know some women who even the 100 milligrams, you know, is enough. Some women have to go higher on the dose of progesterone to really have noticed a significant benefit in that. But it really helps in your quality of sleep. And then it also has been found, there's some women in perimenopause who we treat with progesterone alone, right? Before we even add the estradiol. So it has been found to cause a calming effect, right? And it helps with anxiety. So that hypnotic calming effect can help with anxiety and really help just mood stabilization as well.
So just to hover on that for a second. So for women in perimenopause
Mm-hmm.
who perhaps have no other symptom, have a uterus, have no
Mm-hmm.
other symptom that they can identify, but they have anxiety, they may now go to their physician, their menopause specialist, and inquire about progesterone alone.
Correct.
Okay. All right. That's good to know.
And there are articles, right? That there are articles that have shown the benefits of introducing progesterone alone to help with the symptoms of during the perimenopausal transition.
Okay, great. Thank you. So, and then just to sort of round out the trifecta, if you would offer some information about testosterone.
Sure, yeah. So testosterone is, again, the third main hormone that is produced by the ovary. And what it has been found to do, and what it's typically, what they say the indication for prescribing it is really when, you know, it's really to enhance your libido. Like if you have hyposexual, HSDD, hyposexual disorder, dysfunction disorder, when your libido is low, adding testosterone can actually improve your desire, it can improve arousal, it can improve all, you know, your sexual satisfaction. So adding testosterone has been, that's its primary indication. But also some studies, and again, these are small studies, so it hasn't been conclusive yet, but they show that it improves your cognition, it improves mood, it improves your muscle mass, it improves your bone density and your bone strength. So there are other benefits. I think we were just waiting for more studies to be more conclusive, so that those can be under other indications to prescribe testosterone.
And now women will often ask us here in this community when we're going to offer it, or if we're going to offer it, or do we offer it? Can you tell us the answer to that?
Yeah, so it's considered a controlled substance by the FDA, right? So it's not a substance like when you think about any kind of opioid or any kind of narcotic, it's not something that you can prescribe easily. It requires either an in-person visit, you know, a
Right.
visit where you actually are face to face with somebody. And so for that reason, you know, we're not able to offer it on the Alloy platform at this time.
Okay.
So it really is, you know, something that is out of our control at the
Yeah.
moment, but we're
A
looking to
work
see
in
that there'll be
progress.
change.
Yeah. 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 Okay. Thank you for that. So, Dr. Dombo, what can you mentioned sort of early on in your first minute of speaking, really about sort of looking at or speaking with patients at about 3 months
Yeah.
and checking in with them, how they're doing symptomatically. Before we get to that, what can women expect within the first 2 weeks, let's say?
Yeah. Yeah.
No.
So your body has to adjust, right? Anytime you add something new to your body, that is going to take time for your body to adjust, depending on where you are, right? Whether you're perimenopausal, you're postmenopausal, your body's been exposed to hormones before, or it hasn't. So that 2-week adjustment period is what we say can be the, time frame where you notice side effects. And some of the most prominent and the most common side effects include, again, bleeding. You may notice that, wait, I haven't bled in so long, and all of a sudden I'm starting to have either, maybe pinkish, on my underwear. I'm noticed that I'm having a bit of spotting, or it can be as intense as like a full-on like period bleed, unscheduled, what is going on. So, and that can be scary, when it happens, but that's
Sure.
not something that is uncommon as your body is adjusting, right, to the hormone. So that's one. Another thing is water retention, or, retaining fluid. And a lot of patients will say, I'm gaining weight,
Yeah.
and the scale is going in the opposite direction.
Yeah.
And I think it's really important, right? Really important to remember that, again, your body, like, it will level off. It will get, like, the body has a way of, like, in the beginning, it reacts. It's kind of like, what did you just do to
Yeah.
me?
What did you do to me?
Yeah.
Yeah.
Even though we know that it's good. And I always tell my patients, just, if you can, just be really patient, because your body will adjust, and, the water retention will eventually go away. It can be a very distressing thing. But again, some women don't have any at all. And some women will notice that, oh my gosh, it's unbearable,
Yeah.
for me.
You just made me think of something. Often when a body is reactionary, particularly for a woman, and she's feeling bloated or swollen or inflamed, she may think, and I've heard women say this and ask me about it, I think this is causing inflammation. But in fact, estrogen has anti-inflammatory properties, if you will. So
Correct.
again,
Right.
if you're bloating, it's not the same as inflammation. Is that correct?
So it's water, your body's just retaining fluid.
Okay.
Get rid of it, because estrogen, like, again, with cortisol, we consider cortisol the inflammatory drug. When you have higher cortisol levels because your body has been deprived of estrogen, or you're dealing with some of the fluctuations, right? Like, estradiol can reduce cortisol. So kind of trying to look at it from the perspective of, okay, my body is getting to a place where it is going to be in a better off situation. I'm just going through this kind of rough patch of the adjustment phase.
Okay. I want to ask one more follow-up question, and then I want to get to the questions that have come in. I'm reading them, and they're terrific. Again, to circle back to your 3-month marker. So you prescribe to your Alloy patient, and you check in, and it's about 3 months, and she says what? And I'm assuming this made up patient is using estradiol and progesterone.
Mm-hmm.
So
So
what are you looking for at 3 months? What should she be looking for?
yeah, so I tell patients, like, because a lot of times patients are like, okay, I don't know if I should just continue on the same dose. Do I adjust? Do I tweak? I always say aim for like 70 to 80% improvement in your symptoms, right? I think there is a desire when we start to feel better in the beginning that, oh my gosh, I want to go back to, if things start to level out, but we're not looking for 100%, in terms of 100% improvement in all your symptoms. We want to get to at least 70 to 80%, because if we start increasing the dose to get 100% relief, we can also start to navigate having to deal with some of the side effects, right? And,
Right.
when, and estrogen, these are, hormones that make us feel better. But if we have them in too high doses, our body will tell us, right? Because we're not checking blood work, in the sense that we're
Yeah.
really adjusting treatment based on your symptoms. So looking at how your body starts to feel at that 3-month point, wow, are you at the 70%, or are you still having, like, are you having this really bad bloating? Are you having, um, you know, side effects of breast tenderness, right?
Mm.
Persistent breast tenderness. I'm not talking about the breast tenderness that starts the first 2 weeks as your body adjusts, but like really persistent. I mean, I've had patients say that my breast size is doubled, or they're just like concerned with how their body is responding, right, to the hormone. So
And in
that's
a
what
case
we look
like,
for.
I'm so sorry. Please continue.
No, that I was just going to say, every person is unique and different. So what happened to your best friend may not be how you respond, to the medication. Like, you may have heard someone else say that they had this benefit, and just because it's not happening for you does not mean that, it's just such a delicate balance. So I know that comparison thing is what I tell patients,
Yeah.
let's stay away from that and focus on you.
Great. So before we get back to sort of determining what to tweak and how to tweak it, I saw this question, which piggybacks off of what you just said. Someone says, I just started progesterone estrogen last week. My breasts are so sore. Hopefully this passes, question mark.
100%. I mean, and if it doesn't, so again, give your body at least, like 8 weeks, 8 to 12 weeks. If you find that your breasts are still like really sore, then
Yeah.
you can talk to your doctor about reducing your dose, because I
Okay.
think your body will tell you when something is too high or something is not enough.
And
So
so to that, then, should you be at 4 months with severe breast tenderness or maybe headaches, maybe migraines, what do you begin to look at and consider tweaking?
it depends on the
Okay.
symptom, right? So if, like, for example, if a patient says I didn't have migraines before, and I've noticed that since starting, I'm having these consistent migraines, and we're past the 2 week point, we're into like 4 months, as you said, then we might look at, okay, we need to bring down the estradiol dose, maybe we
Okay.
need to tweak your estradiol dose. So that could be, one indicator that needs to come down.
What would be maybe say three others, or I don't know, I'm just making up a number, that estrogen in particular needs to be decreased?
Okay, so let's say we're at 4 months,
Mhm.
you're still on the same dose, you're having the breast tenderness, that's where I would say, let's bring that down.
Okay.
Would be another one. Again, another common complaint can be nausea, right? So
Really?
yeah, some patients will have persistent nausea that just they're not able to tolerate. And that can, again, be either your progesterone or your estradiol. So I typically say, you know what, we can either, you know, make some tweaks to see which one is like, or do you notice after you've taken which one, do you notice
Mm,
most, you know, the most nausea or GI upset. And a lot of times, again, it's progesterone, but estrogen can also cause that. And then water retention. If patients are like, I'm 6 months in and I'm still bloated, I'm still uncomfortable, I don't like, how I feel. It can, again, it can be the progesterone or it can be the estradiol. So that's why it's so important that you check in with your doctor, because then they can kind of look at, okay, which can we tweak to be able to get you to, less of the side effect that you are actually experiencing.
terrific. And thank you, Dr. Dombo. I'm sort of accidentally putting you on the spot with these hypotheticals, but as we kind of unravel sort of how to approach and navigate getting to feel better, I think it's important that people sort of let bells go off in their head about certain things. The other thing that you just said that I think is so important, and I just want to amplify here for a second, I talk about it in support groups all the time, is to track your symptoms. So when you said, as a menopause specialist, do you notice this or do you notice that? Just keeping brief track of how you're doing when you're feeling that way is so informative to both you and your physician.
Yeah, because at the end of the day, we're trying to help you, right? What is it, like, the more information that you can provide, the better we're able to assist.
Yeah.
It's not, not every person responds the same way
Yeah.
to hormones. It really is your unique body chemistry interacts very differently. And that we just are here to try to help figure
Yeah.
out.
Thank you. Thank you. Next question. How do you approach the treatment of women who want to restart estrogen therapy after the age of 60 or 65? This question is asked often and really important. You touched on it already, but can you speak a bit more to this?
Yeah. So, as I said, there is an optimal time to start, estrogen, and progesterone therapy. And usually that's under the age of 60 or within 10 years of your last menstrual period. So if, let's say, you're outside of that window, it doesn't not mean that you can't start. It just means that we take a look at, okay, let's take a look at your family history, your personal medical history. What are your risks for heart disease? Do we recommend getting like some testing done for you to get a coronary artery calcium score to see where you are, if you have any risk of coronary artery disease? And then we offer like transdermal. We can offer you transdermal options, which are safer to take than the oral estradiol. So it's just a nuanced, situation where we take a look at what your risk factors are, what tests could be done so that we could mitigate, um, the concern that most people have with starting after age 60 or 65. And as long as, like, we have a discussion about the risks and the benefits, there's not any absolute reason that we cannot start you on hormone therapy.
Oh, that's so great. Thank you. That's so helpful. Someone asks, I remain confused as to why and when a doctor prescribes birth control versus hormone therapy. I can't seem to get an answer that addresses all the side effects, benefits, and risks in direct comparison. Are some symptoms made worse from the birth control pill?
Got it. That is actually a really great question. Really good question. And I love all the nuances to the question as well. So I'm going to do my best to describe part of the thought process behind why that is an actual offer, on the table during perimenopause, versus, starting menopause hormone therapy, because it's really, it's again, it's so nuanced, but I'll start with explaining the pathophysiology. So
Great.
perimenopause is when you have these okay, so we have estrogen going up and coming down day 14, it peaks, and then progesterone starts to go up after. So, but during perimenopause, we have these wild fluctuations, right, in your hormones. And so the reason why the birth control pill can be offered is because those wild fluctuations are what cause some of the symptoms we have, and they also can cause menstrual irregularities, right? So where we start noticing that, oh my gosh, either I'm bleeding for, 21 days, I had an anovulatory cycle, so I'm bleeding, for, several days, or I may, notice that, my periods are really, really heavy during this time. So what the birth control pill offers, number one, there is still a chance that you can get pregnant during this time. So it offers contraception. It offers a stabilization, right? Because it ends up shutting down your ovaries and you just get a steady state of hormone. So those fluctuations that occur are being made more steady by the hormone in the low dose birth control pill. So the hormone in the low dose birth control pill is higher in amount than what's in hormone therapy, menopause hormone therapy, because what it does is it tells your ovaries to keep quiet. Just quiet.
Right.
Just quiet
Yeah.
down a minute. I know you're having these fluctuations, but we're going to just, cause you to calm down. So that's how that works. And then it essentially helps regulate periods. And, it works in that way, and it can be beneficial. Hormone therapy during this time really is purely to help with the symptoms that you're experiencing. So let's say, again, you're having these wild fluctuations, but you are having all the symptoms that are associated with hot flashes, night sweats, mood swings, or you're not even having, the hot flashes and night sweats, you're just having mood symptoms. So adding estradiol to help with the symptom that's all it's going to do. It's going to help with the symptom. It's going to add some estrogen, some progesterone to help, so that when you have the lows and the fluctuations, right, the lows are covered by an amount of hormone.
Okay. All right, great.
Sense?
It does make sense. And that question also does come up frequently. And I think some women get a little frustrated if they're recommended a birth control pill, or they're recommended to maybe remain on the birth control pill that they're on. I was one of those women who was told, you can just stay on the pill and kind of ride this out. And I thought, well, I don't want to keep on the pill, and not, for whatever cockamamie reasons I had, but I became increasingly symptomatic and ended up, enjoying the benefits of MHT. After many years, though, it took a long time. I thought I was sort of muscling through and doing okay, but I wasn't hot flashing for many years. And once that started, it was no longer reasonable to go without.
Yeah.
But that's very helpful. Thank you.
And I also see women who, they are on the pill already and they are having symptoms, right?
Mhm.
So then the question then becomes, okay, if you are symptomatic while you're on the pill, you may benefit from transitioning to, being on.
That's really helpful here.
Yeah, yeah.
So you can be on birth control pill, begin symptoms of perimenopause that the birth control pill is not addressing. And
Mhm.
so it may be time for a conversation about transitioning to MHT.
Correct.
Awesome. Thank you. How do we dose HRT for prevention purposes? CVD, OP, GSM, dementia, etc. I'm asking for patients who are not experiencing debilitating SX symptoms.
Right. So that's a really great question. And you know what? I am looking forward to all the research that's going to be done to give us guidelines and guidance on this. Because
Yes.
truly, like, there is not any, piece of literature that shows studies that have shown or proven that this particular dose is going to help reduce the risk of, you know,
Okay.
this, so I think there's just a lot of research that still needs to be done. And,
Mhm.
it's right now, it's a very individual, practitioner, dependent, a decision.
Okay, thank you. Is it safe to use progesterone orally without the estrogen patch? I'm just waiting for the patches to arrive, she says.
Yes, it is very safe to do that. And as I mentioned before, progesterone can be, used to help calm and stabilize mood, because when women who have just mood symptoms and insomnia during perimenopause can go on progesterone and notice significant improvement in symptoms. So it is 100% fine and safe to take progesterone, during.
Is there anyone for whom progesterone only would not be recommended?
I mean, there's nothing that I can think of that
Okay.
would be like, oh, we can't, because even, the risks, when you think of the contraindications for like hormone therapy,
Yeah.
of like liver disease, we think of, breast cancer, like there's certain contraindications that we know of for MHT. And a lot of times it's the estrogen, like in MHT, that contributes to a worsening, or not a, but an instigation of worsening, like liver, if you already have active liver disease,
Yeah.
right? Estrogen is what really is, the liver works very hard to break down. The liver break down all hormones, but it's truly estrogen that we are most concerned about. Even when we think of, breast cancer survive, like it's like estrogen alone, when it came to the WHI study, like
Mm.
there were beneficial effects, but I think the contraindications are
Yeah.
what we get concerned about when it comes to it's estrogen.
Okay.
Progesterone is a lot safer to use.
Perfect. Thank you.
Mhm.
Somebody asks, is memory helped? She wrote, LOL. Do they call this brain fog? I think this is probably in response to when you were talking about all of the benefits of estrogen in particular. So can you tell us a little bit about memory, cognition, brain fog? What's helpful to that?
So again, I think looking at just the benefits of estrogen, and estrogen on the brain, so many women come in during perimenopause and menopause when there's the fluctuations, right? That they complain of brain fog, they complain of, memory issues. I can't remember why I'm in the room. I
Right.
came to a room, where are my glasses? I can't remember where I put the keys. Or we had a conversation, I can't remember. And so what estrogen does, it really helps the synapses in the brain. So when the 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 synapses in the brain, so the neurons in the brain connect, it helps improve
Okay.
those
That
connections.
connection. Mhm.
Yeah, so when it comes to cognitive function, estrogen is very helpful, but then also testosterone has been shown to be helpful as well. So I think, again, what was your question? I'm sorry.
No, she was more commenting about brain fog. But you did make me think something, Dr. Dombo, if I can toss this in here, and maybe it's anecdotal,
Yeah.
but I found that my brain fog, which I struggle with, I'm not gonna lie, but it is largely improved when I'm sleeping better. And progesterone helped me do that. Maybe it's the estrogen as well, but from what you said
Right.
about progesterone, I certainly know it's that. Um,
Right.
if you're losing sleep, cognitively, you are suffering.
Exactly. So I think at the end of the day, like, a lot of the mood symptoms that we know of, a lot of the mood symptoms are a result of unstable sleep patterns, right? So if
Mhm.
you're not sleeping well, you're gonna feel like mood wise, you're not doing well. And so the benefit of looking at adding estradiol and progesterone is to really make sure that we are improving your sleep so that you can actually overall feel better.
Okay. This question is a bigger one. Is breast tenderness always the result of excess estrogen? That's one part of her question. She says, I recently started the 0.5 patch, which I started on day 7 of my cycle. And I noticed tenderness around ovulation. My cycle is still fairly regular, so days 14 through 16. So I pulled the patch off.
Okay.
Perhaps the patch is not something I need, though mood and brain fog is awful, even with cycling oral progesterone. So there's a lot to unpack here.
Right.
If we can get through it, this is a great question.
Can you read that again and just break it down?
Absolutely. So the first she says is breast tenderness always the result of excess estrogen?
For the most part, but it can also be because of progesterone. You know that like right before your period, like you can start to notice your breast starts to get sore. So
Sure.
that's when your progesterone levels start to go up. So even physiologically in the body, progesterone can contribute to breast tenderness, but usually we see it most commonly with estrogen.
Okay. She goes on to say, I recently started the 0.5 patch. Her cycle is still fairly regular. She noticed tenderness around ovulation, so she pulled the patch off. Can you speak to that for a moment?
Okay, so
She removed the patch because she was experiencing breast tenderness.
tenderness. Right. I typically, and again, it's hard to say because I don't know, has she been on the patch for a while? Is
Right.
this, it's hard to say, but I typically say that the estradiol patch provides a steady state of hormone, and
Okay.
I don't recommend taking it off and on within your cycle. And if she has just, if she has just started the patch and noticed the breast tenderness, I would give her body at least some time to adjust because it
Okay.
can take at least 2 weeks for your body to adjust to an extrinsic hormone and it eventually levels out. But again, if it's persistent and this has been going on for 3 months, then she needs to talk to her doctor
Okay.
because it could just be the dose.
Okay. Finally, she says, perhaps the patch is not something I need, although mood and brain fog is awful, even with cycling oral progesterone. Can you speak a little bit about cycling progesterone?
Yeah. So a lot of my patients who are in perimenopause, I tell them to take the progesterone on days 15 to 27 of the
Okay.
cycle because that kind of mimics, you know, your actual cycle and how progesterone is secreted, by your body. So the benefit of cycling is that you are reducing your risk of any kind of breakthrough bleeding. So what I
Sorry, quick question. So are you speaking about cycling progesterone for women who are still getting a period? And is this different for women who are no longer?
Got it. Okay. So for women who are in perimenopause, who are opting to go on hormone therapy, I recommend if you're having a regular period, you can cycle the progesterone by taking it on day 15 to 27 of your menstrual cycle. If you're not having regular periods and you are taking progesterone, the recommendation, especially if you're on a higher dose of progesterone, like 200 milligrams, you need to take it for at least 12 days a month.
Okay.
So those are two separate scenarios, but I think specifically when it comes to women in perimenopause, the benefit of cycling is that it reduces the chances of more breakthrough bleeding.
Okay. Okay. Thank you. Next question. I am using a compounded cream of estrogen, progesterone, and testosterone. The testosterone was to increase libido. It has not worked at all. The progesterone was added because my doctor thought it helped the estrogen work better, even though I don't have a uterus anymore. I do have my ovaries, and the estrogen is definitely helping with hot flashes. It is much more affordable to use estrogen alone. Do I need to wean off of the cream, or can I just go straight to estrogen only?
So the fact that you don't have a uterus and you've had had a hysterectomy, it means that you do not necessarily need the progesterone. I'm not sure if your doctor added the progesterone because you were having trouble falling asleep, but that would be the benefit of the progesterone in that scenario. So
Okay.
really, if the progesterone is not helping, you don't need to be on it. But as far as the testosterone, the question would be if you're not getting relief, symptomatically, then the question would be, can your dose be increased? But again, a lot of times we want to make sure that your dose is not, you're not overdosed with testosterone. So you would have to get your level checked before any kind of increase would be done.
Okay, thank you.
Yeah.
Speaking of, how would one know or test for overgrowth of the uterine lining, particularly if using bioidentical estradiol, but also other MHT estrogen?
So a lot of times when there's an overgrowth, it shows up as like you're having persistent bleeding. Bleeding, we usually say, is typical of the first 3 to 6 months. If you're having bleeding outside of that time, then you know that, okay, wait, we may need to kind of check and see if there's any issue that is resulting in the fact that you're having persistent bleeding. So one of the things that we can do is do a transvaginal ultrasound to take a look at the endometrial stripe, or we can do an in-office like endometrial biopsy. But again, this is done in a gynecologist's office where
Right.
we get a little sample of tissue from that inside lining to determine whether or not the lining is healthy, or is there a concern for, other things that could be causing the bleeding.
Okay, thank you. I like this question. Why are we waiting so long to prescribe HRT to perimenopause individuals? And why so long to wait for a DEXA scan when osteoporosis is silent and can occur as early as 40?
Yeah. So those are all great questions. And I think it goes back to like our education, right? The education of the OB-GYNs, the PCPs, the providers.
Yeah.
Truly, like, hormone therapy was always relegated as something that you prescribe, like, after you've had that 12 months of no period. That is what I was taught, through my residency training. And with that, we didn't even get a lot of, training on it. So
Right.
th- there's a lot that is not known, and a lot that, research that hasn't really been done on, caring for women during this perimenopausal transition. So a lot of what we're doing is, that's why there's a lot of pushback, right, from a lot of doctors, because this is something that has not been typically done, and we're learning how we can help women, who are going through this time.
Yeah. Thank you, Dr. Dombo. This question is interesting, and she, I think, is speaking just, this is going to help us sort of understand the nuances of care. She says, and I believe she might be quoting you, progesterone levels to be prescribed in proportion to estrogen levels. But if we adjust the estrogen to reflect what's being absorbed transdermally, so a woman could be on high doses of estrogen because her absorption rates are low, hence circulating levels are the same as somebody on a much lower dose of estrogen. What do you do with progesterone prescription levels?
So if you're on higher doses of estrogen, you need to be on a higher dose of progesterone to balance out that beneficial effects of the estrogen. Just as I mentioned before, estrogen has so many great things that it does, but on the other end, it can cause overgrowth of that lining. And that's what we really want to avoid. So a lot of patients, like, if they have a diagnosis of what we call premature ovarian insufficiency, right? They are under 40 and they've not had a period in 12 months. We start them on higher doses of estrogen. And for that higher dose of estrogen, we need a higher dose of progesterone, because we want to make sure that that lining, doesn't result in overgrowth.
And when we are talking about absorption, what is that about? That's a red flaggy thing to a lot of people, and I don't know that all of us really understand what that means.
Okay. So every person absorbs estrogen that is applied transdermally differently. And there's certain forms, right, of estradiol that have better absorption rates than others. So for example, if you're looking at, using an estradiol patch versus the Evamist spray versus the Divigel, right? Your body tends to, the absorption rate of each different form is different.
Very okay.
So you're not only dealing with the form, but you're also dealing with your own absorption, right? Because
Right.
each person, absorbs it through their skin, and that barrier can be a source of great absorption, or it can be resistant to absorption. So there's so many different factors that come into play when it comes to absorption, but those are the two main things, the form, and then you're also your skin barrier.
Fantastic. Thank you.
Mhm.
Can progesterone be topically applied for inflammatory joints?
So progesterone can be topically applied. Um, However, it is a larger molecule. So if you're using progesterone simply, as a aid in helping sleep, without any additional estradiol, that's separate. Using it for inflammatory joints, I haven't heard of that indication yet. But again, if you're using it with a form of estradiol, you want to make sure that you are using a progesterone that will be able to protect the uterine lining. And topical progesterone is a very different molecule
Right.
than oral. So that is the only thing that I would have to say about that. You just want to make sure that you are getting adequate protection for the benefits that the estrogen dose provides.
Terrific. Thank
Yeah.
you. Will vaginal, excuse me, estrogen cream, such as the Amazing product, two different things, help to prevent the nighttime urge to go to the toilet? Can you talk about the vaginal estrogen cream, which is not the same as Amazing, the product that we
Yeah.
offer?
Yeah, I could definitely do that. So vaginal estrogen cream is a cream that is applied inside internally, but also it can also be applied externally. And the purpose of estrogen in the vaginal tissue is to help it become re-elastic and also it kind of what we call re-epithelializes the tissue. So it really helps the tissue kind of have versus a thinner, a more thicker, consistency, so that the tissue itself functions in a way that it is meant to function. So it
Mhm.
also helps the bladder. So when we look at the bladder lining, it can get very thin, and that can also contribute to some of the incontinence symptoms that you have, recurrent UTI symptoms. So when we add vaginal estrogen, we're trying to really re-epithelialize the tissue in the vagina and the bladder so that you're not having the pain with intercourse that's from vaginal dryness. So that's the reason how that works. And once you have the tissue a lot healthier, when you apply the Amazing cream, the Amazing is what helps increase blood flow to the areas that it's applied. So the clitoris, the topical areas where Amazing is applied helps just increase sensation and blood flow so that you have an overall more pleasurable experience.
Terrific. Thank you so much. And to that, just for those who, excuse me, may not know, because this comes up a lot as well, there's vaginal estrogen and lube, which is also two different things. And I've heard women sometimes use them interchangeably. So you've explained vaginal estrogen. Lubricant is something else.
Yeah. So lubricant, it can either be water-based or oil-based, and it really just helps reduce any kind of friction that occurs during intercourse. So it makes intercourse a lot more pleasant by reducing, the uncomfortable friction.
Great. Thank you.
Yeah.
I can't believe we've gone 50 minutes already. This is going very quickly. Question. I'm 41, struggling with insomnia, brain fog, low mood, anxiety in my luteal phase, and I've been using 200 milligrams of progesterone for the second half of my cycle, which does help some. I was told I could start using 100 or even the full 200 milligrams for the other half of my cycle, but I feel I want to stick with the cyclic format. What other
Mhm.
suggestions do you have? My cycle is still regular, so no estrogen? Question mark.
Okay, so the question would be, there's a lot that I don't know, like your whole history, and how old you are,
She's
but
41.
41, okay. I
Mhm.
mean, some form of even like a Evamist, it's worth a try to see whether or not that may help. I always tell patients, you can try, right?
Yeah.
And there's improvement. If there isn't improvement, then it's like, okay. But I think sometimes it's important to realize that the whole process is one of trial and error, where we try to figure out what works best for your system, right? So
Yeah.
at 41, you may need and the beauty of Evamist is that you can do one spray, see if that works, go up to 2 sprays, see if that works. And if it doesn't work, then estrogen is not what you need.
That's so helpful. I really appreciate your amplifying the trial and error part too. I think you threaded that throughout this conversation, and there is this, awareness of the nuances of menopause care. But truly, truly, you can try. And I would say, or you would say, for up to how long before you determine this is not working for me? Certainly, if you become symptomatic in some way that's particularly severe, that's your, as you said, your body letting you know exactly what's going on. But is it about 12 weeks that you, I think, mentioned to sort of say, all right, I've tried this now. I've tried even missed one spray to my 200 milligrams of progesterone for 12 weeks, and I'm still feeling brain foggy and low mood and anxiety. Is it time to go up to 2?
I mean, I typically say, let's say you're just on the progesterone, or we start you on progesterone. I say give your body at least 12 weeks to adjust to that, right? Because when you're looking at a particular dose, that's how long it takes for your body to kind of experience what we call the maximum benefit of a particular dose. Let's say you're going to add Evamist after 3 months, right, of being on, let's say you just start on progesterone. Let's say we start you on the 1 spray. I can say 2 weeks is enough time on 1 spray. If you don't notice a difference, you can actually increase it to 2 sprays. And if after a period of, again, 12 weeks on a particular dose, you're not noticing a difference, then I would say, okay, your body is really telling you something at that point, because you should experience the maximum benefit of a particular dose within a 12-week period.
And then it may become an issue of the modality. Maybe you need to switch.
Exactly. It may,
Right. So it's a commitment to find your sweetest spot.
exactly. And I tell patients, whenever they come to me, I'm like, what I'm asking of you is patience. You need to give me patience, right? I will
Yeah.
be here for you, but just like it takes a bit of patience to figure out what works best for you. Some people hit it right on the first go, and some others it takes a little bit longer.
Oh, thank you. I love that. Next question. Can I stay on forever? I just started it a week ago. I'm 54.
So the interesting thing is, I think what happens is that your body will, tell you whether or not you can stay on it forever. So at 54, let's say 4 or 5 years down the road, it's important to update whoever your provider is, or your clinician, with any changes in your medical history. Because if you have any changes in your medical history, it's important that we determine whether or not this is safer, it's safe for you to continue. So we look at, or we may say it's safer for you to switch to a, if you're on an oral option, maybe a transdermal option. So it really depends on how you do, and how you change over the years, to determine whether or not it's safe for you to continue.
Okay.
But if there are no issues, you can continue.
Yeah, just write it out. Okay. Thank you for that. Another really important question to clear up. Will the estrogen patch help with any of my vaginal dryness, itching, pain with intercourse problems?
So the estradiol patch has estrogen that it's systemic. So it will eventually help. But if you're looking for a, shorter response time to those symptoms, vaginal estrogen is the way to go. So a lot of times, I'll have patients who say, you know what, I just kind of want to add one thing at a time. I don't want to add too many things at once. So starting with an estradiol patch, I just make them aware, yes, that'll eventually help you, but I can't say how long it'll take. It may take a year, it may take, 9 months. Whereas if you start with vaginal estrogen, the impact is direct and more immediate.
And I'm not the doctor in the room, but I will say I always encourage women to get their vaginal estrogen in addition, unless, and correct me if I'm wrong, you have undiagnosed vaginal bleeding, correct?
Correct.
And then you need to speak to your practitioner anyway about
Correct.
that. Okay.
Yeah.
Would individual hormone lab levels help to get the best dose?
So I think I say this to all my patients, the North American Menopause Society, the American College of Obstetrics and Gynecology, we all kind of take the stance that, during perimenopause, when your hormones are fluctuating, you can have blood drawn the same day, 12 hours apart, and they be drastically different. So
Mm,
truly labs, they provide, and they provide us with a number, but at the end of the day, we're taking care of, we're treating you, the patient. So it really is based on your symptoms versus a number, on a piece of paper. So I tell all my patients, if you want to get labs done, that's great, but that's not what I require to be able to determine, to come up with a treatment plan. And I'm talking specifically about hormone levels, your estrogen, your progesterone, estrogen and progesterone levels. Testosterone is different. Testosterone can be, you require a blood test in order to initiate testosterone. However, with estrogen and progesterone alone, we're really looking at symptoms.
thank you. Dr. Dombo, I know your time is precious. Can you give us another 10 minutes?
Yeah, I can.
Great, thank you. If we haven't noticed any change in menopause symptoms, should we wait until 3 months before asking about increasing estrogen?
Well, you can definitely talk to you can ask. I think what's important to realize is that, you know, don't be surprised if your, clinician says, hey, it may be worth, giving it the time that it needs to be able to experience the maximum benefit. Eva Mist is a bit different. We usually say, you start with one spray, and then, after 2 weeks, if you're not 2 to 3 weeks, if you're not noticing a significant difference, you can go up to two. So Eva Mist is a bit different, but
Okay.
all the other, like the patch, the gel, it's typically, we say the maximum benefit can occur at the 12-week point.
Okay, thank you. If I get GI side effects to vaginal estrogen cream, will I also get GI side effects to transdermal estrogen? I've never heard this. This is
That's
interesting.
really interesting that your body responded in that way. I would say you may, and it may be worth looking at, how do I start maybe on the lowest doses, and then looking at the transdermal, options, and or at least for the estradiol, and then with the progesterone, it may be worth inserting it vaginally versus taking it orally. There are kind of different things to
Mhm.
consider, or just saying, you know what, I may just start with progesterone, see how my body does, and then introduce the estradiol, So it's a very personal, and nuanced thing, because
Yeah,
not majority of women don't have GI side effects with something that acts locally in the
yeah,
vagina.
yeah.
So it's
Thank
just
you.
very sensitive.
Yes, to piggyback off of that, she does go ask a separate question was, would it make sense to start estrogen and progesterone separately to see if and which may cause side effects? Is that something you would recommend?
So starting estrogen without the progesterone, I would not recommend, right? But you can start the progesterone, and then you can add the estrogen. So I have some patients who feel like they don't want to add two things at once. So they want to start on progesterone, and then a week later add the estradiol patch, or, whatever source of estradiol they've chosen. So you can do it that way, gradually. But the one way that would not be advised would be to start estrogen without the progesterone.
Yeah. Um, Again, I think just to expand on this one more time, can different modalities of estrogen cause different side effects? If I have bloating with, excuse me, 3 sprays of Evamist, would a 0.50 patch cause the same issue? Could modalities be an issue or dosage?
Yes to both.
Yeah,
Yeah, both. Yeah, because if so the patch and the Eva Mist have different absorption, right? So the
right.
question is, is it the actual dose, the amount, of estradiol that's in your system that's causing that? Or is it the way that your body is, has absorbed, like the absorption, of the estradiol causing those effects? So I always tell patients, be flexible, because one form may not work as well as another form for you. And it's just a matter of doing trial and error and seeing what your body prefers, better.
Okay, I'm going to ask two more questions before I close this out. This is a larger statement. I'm 45, still cycling, started estrogen patch just under 12 weeks ago, or about 12 weeks ago. Prior to that, I was given 100 milligrams of compounded progesterone for luteal phase only. I had taken that for at least a year. After the patch, I was told to take progesterone every day, same dose. When I'm taking the progesterone, I feel bloated, swollen, uncomfortable joint pain, and inflammation. The only benefit was improvements in sleep. Will this improve? Could I need a different form of progesterone? Would someone in this position go back to only taking in luteal phase? I always had a regular 28, 29-day cycle, but went to 45. I took a break from progesterone and cycle came. So confused and just want to feel normal and not huge and swollen.
So I'm not exactly sure the dose of the progesterone cream, and it could be that the
100 milligrams, I think is what, prior to that, she was given 100 milligrams of compounded progesterone for luteal phase only.
okay.
I don't know what it may
The
have increased to.
It's interesting to know if is it compounded progesterone in a tablet form, or is it compounded progesterone in a cream form? I'm not really clear there, but I do think that especially with some of the side effects, you mentioned like the bloating, like if it's possible to try using the compounded progesterone vaginally, if it's in the pill formulation, that would be one way to see whether or not your body responds differently. And then the other question would be, if not, you may be better off using a progestin, right? Something that may offer you less, bloating side effects, which is a very different form of progesterone. It's just a synthetic form of progesterone. Again, a lot of women don't want to go on synthetic, but there may
Yeah.
be situations where you're looking at what really will help you feel better.
Yeah, thank you. I've had side effects to micronized progesterone years ago, so I'm afraid to take it again. Are there other ways to get it so it doesn't cause the side effects? I think you sort of just spoke to that.
Yeah, I think so. I mean, you can try inserting it vaginally and see if that reduces your risk of side effects. So instead of taking it orally at bedtime, you insert it vaginally and see if that kind of reduces your risk of whatever side effects you were experiencing.
Finally, can too much estrogen cause heart palpitations?
So I would say too little estrogen can cause heart palpitations, and too much estrogen, can also cause heart palpitations. So that's why it's so important to get to that sweet spot of what your body responds to, without too many side effects. The benefits of a dose that works for you without the side effects.
Dr. Dombo, I just looked down at this one question that had come into me that I want to offer to you just because I think it sort of helps also round out this conversation around hormones. Somebody asked, what lifestyle adjustments can I make alongside hormone therapy to maximize its benefits? Are there particular exercises, diet changes, or stress management techniques that help? I like this question because as you talk about the 70 to 80% sort of improvement with menopausal hormonal therapy is a goal. And that leaves room for all of these other things, which also it may increase its efficacy, increases our, our health outcomes, our day-to-day. Can you speak about some of that?
Yeah, so I think it's important that, looking at what are some things that are going to help me reduce the stress in my life, because again, your ability to cope with stress may be diminished during this time. And anything that you know of that you can, whether it's meditation on a regular basis, yoga, incorporating a practice on a regular basis that's going to help you reduce stress is so important, because again, stress is going to increase your cortisol. Lower estrogens increases cortisol. So you want to be able to look at what are ways that I can incorporate a regular practice to reduce stress in my life, number one. Number two, nutrition is so important when it comes to what you eat and what you put in your body. So we typically talk about the Mediterranean diet, something that really is good in, looking at, the amount of protein, the amount of fiber, drinking lots of water. It's really important to prioritize some of those things, because I think at times being busy, we're just looking at, okay, what do I need to do next? What do I need to do next, and get through the day? But again, these small changes, like, routines and your mindfulness, routines and looking at your nutrition, making sure that, you have a routine around, resistance exercise, where you're increasing the strength of your muscle, increasing the strength of your bones, on a regular basis. Those are so important. Hormones are just one aspect, but these things are equal, like they have equal weight when it comes to your overall wellness during this time. And so I think through Allo, we're just trying to look at how can we, provide access, right, to the hormone piece, but it's also really, really important that all the other parts of your life, like your social connections, right?
Yeah.
That's huge. I talk to patients all the time. What brings you joy? I ask sometimes. But your social connections are important. Being able to find those people who you can be true and authentic and talk to about what's happening in life without shame, without, like, that is just such an important piece in you as an individual thriving.
Thank you, Dr. Dombo. You're just fantastic. We're so glad that you're here. And you are in Los Angeles. So for those of you lucky enough to be out in that area, Dr. Dombo is your prescribing physician, and in other states, I'm assuming, as well. To everyone watching, thank you so much. Dr. Dombo, thank you for breaking down the nuances of MHT with such clarity. For those of you watching, I think the thread here is that, your health journey is unique. Finding what works best for you is a process. Don't hesitate to advocate for yourself. Seek out the support you deserve. Thank you so much for all of your questions. We're going to have to do this again soon, Dr. Dombo, and I'm going to ask you to carve out even more time next time, because the questions are just invaluable to everyone. So thank you. And thank you to everyone who came, and we will see you soon.